Maxine Hayes, who's with the Washington State Department of Health. And then it'll break out for the second hour into small group discussions, and they're on various topics. And I'm going to be on one on health disparities with Dr. Freddie Overstreet in the School of Medicine. But since you hear from me a lot, you might be interested in some of the other ones: community outreach, pipeline activities, narrative medicine, local advocacy, state advocacy, and practice-based leadership. So that's 2 hours this evening. If you have an open evening, feel free to come and let me know, or I'll see you there. And there's also dinner. So if you're going to be in lab late, you can just eat there. So there are 2 dates left for 45th Street Homeless Clinic. May 9th, which I guess is Thursday. Yeah. And then May 23rd. And those hours are in the evening. So if you've signed up and you're approved for that, go ahead and contact. I actually don't know who the coordinator is at. Does anyone know this year?
Connor and Iman.
Connor?
Connor and Iman.
And Iman, okay.
Do you have to be sign up for the clinic in order to volunteer for those events?
Yeah, so there's a lengthy application, and you can get that through Memory or one of the 2 coordinators. And it's paperwork, and it'll take a few weeks to process, and then once you're approved, you can volunteer. So another thing that I haven't advertised before is the U-District Conversation on Homelessness, which is a group of community members from churches, from housing projects, from university, from all the different players in the university community. And each month they have a conversation on a different topic, and those are usually held on Mondays. So this month the conversation on homelessness is next Monday, May 13th in the morning. And it's very flexible. If you can't make the whole thing, the last hours for small breakout groups, and the first hour is usually the keynote. So this session will be on alley ministries, so how the UT-UMC serves different places around the U-District. And it's a great way to meet different people who are interested in homelessness and get great ideas. And the parking initiative in Ballard, where you can live in your car, and that's hosted by different churches, that actually started out of this group. So the Safe Parking Initiative. So stuff that actually makes an impact is generated in this conversation. So if you have Monday morning off, feel free to go. Contact me kind of for more information, so I can kind of get you clued in on what exactly happens, and then I can let the coordinator know. Also, you may have gotten an email last night about the Union Gospel Mission Dental Clinic. So that's for dental students. 3rd and 4th years will be doing regular dental care. I think all the people who will be doing that have already done that, so they're familiar. And 1st and 2nd years, it looks like there's an opportunity to assist, do radiographs, do some prophies, and then help set up and clean up. And you may have volunteered as an undergrad doing that as well. So it's great to continue that down there. And Juanita's awesome. So it looks like there's 2 requirements. There's an online application which John Paul sent out, and the post-exposure protocol as well. So contact him if you're interested in participating on May 18th. And that's Saturday before the spring barbecue. One more thing, which is still kind of tentative, but I wanted to let you know because a lot of people have been asking me about volunteer activities since it's the end of the discussion sessions. So there's a tentative date for June 7th at 6 p.m. to do teeth and toes at Roots. So if and that'll be interdisciplinary. So if you're in the School of Dentistry, you can be doing, I think we have an affiliation agreement, so you could be doing screenings and maybe fluoride application, oral hygiene instruction, distribute oral hygiene kits. If you're in the schools of medicine or nursing, you could be doing foot care, and you may have to have already been approved, gone through their training to do that, but it might be taped, so you may be able to make that up. And I'll send you more information about that via email as I learn more. Also, if you missed a discussion session, those are available. The 3rd video is still unavailable, but will be up by the end of this week. I just got the last discussion session video yesterday, and I'm in the process of making a makeup exercise. So those you should be able to complete starting this Friday or beginning of next week. Don't forget to do the surveys today, and also sign in at either end. All right, so since this is the last discussion session, I thought I'd do a recap of, where we started, where we've gone. So this will be the 10th discussion session. We had a range of topics. We had Christine introduce us to how does homelessness happen, who in our community is homeless and how do they get there. We talked about the youth facilities at Roots and just kind of got a good understanding of what leads to homelessness. After that we talked about oral health issues. We had Shelby Coolidge. Nancy Amade talked about advocacy and public policy, pharmaceutical, children, substance abuse. So we've kind of gone through a range of topics, and there's still a lot more. You could probably break out each of these into smaller categories and do more in-depth discussion on these. So we've gone through a lot this quarter. So what did we learn? Hopefully everyone can take something away from this. So there are as many ways into homelessness as there are out, and contributing factors are social, cultural, legal, and political. And we kind of talked about, when we had the guest speaker from Vancouver talk about harm reduction and the background that kind of led to a drug problem in Vancouver's downtown east side. We kind of saw how that progressed through history. And then also when we had the speaker talk about the history of Seattle and Skid Row, different factors that can kind of contribute to a problem in the future, and maybe we can prevent those along the way. And there are access barriers, and we can help break those down, whether it be transportation or language or proximity or just getting into an office. There are lots of different barriers that we talked about this quarter, and these barriers are especially important to homeless populations. So health issues, we can see from talking about chronic diseases and substance abuse. We may learn a little bit more about domestic violence today. There's a lot of things that go into the health of homeless populations, and it's a complex ordeal that is pretty widespread. When you have to, balance finding housing or food for that night, you might give up your appointment at the doctor. So, you're making tough decisions. As a healthcare provider, it's important to know, what is available. I think we've learned a lot about what services are out there and how we can connect different people to those services. And then since this is an interdisciplinary class and we've had interdisciplinary outreach, communicating with other healthcare providers, even if it's in your same profession or outside of your profession, not only improves the care that you can give, but it helps you to learn and grow about their profession, about different ins and outs of the system, and then it can strengthen your profession by strengthening yourself. And then solving issues in homelessness, doesn't take just one person. It will require innovative thinking. We learned that with the harm reduction, with the safe injection site, and collaboration among professions. So what can we do? So we learned in talking about chronic medical issues that you don't want to compromise the care that you're delivering, but accommodate and set reasonable goals, set things and expectations for the people you're serving. Do your part, give back to the community, but don't forget to take care of yourself. Understand that decisions people are making, they're having to balance between lots of different things, and Dr. Reddy talked about that last week. And some of those decisions you might not agree with, but don't hold those decisions against them because you're not in the same place as they are. And this actually, I gathered these from the lectures and the discussions. This actually comes from the dental school pledge that my class will sign soon, and demonstrate compassion, empathy, and understanding for patients and colleagues. And I think that's important in any profession, and we'll be signing that soon. So I hope that what you learn in this class can kind of strengthen your compassion for marginalized populations. Apply what you learn here. What we learn here doesn't only apply to homeless populations. You can learn to care for other underserved populations. So wherever you serve out in the field, understand that each patient's a different person, and that you should have some skills by then to be able to treat those individuals. Being here, being out in the community, you're going to be a leader in your profession, so continue to do so. Continue to do outreach, continue to be there for the community. And then advocate for the homeless. So Nancy Amade came and talked about advocacy, and a lot of you went to Dental Action Day, so continue to advocate for them and other underserved populations, wherever that may be. So a couple quotes. The first one's actually from a student in the class, which I really enjoyed. By speaking up, advocating for homeless, marginalized, we can begin to make a difference socially, politically, and personally. And then this Churchill quote is actually one that I love and have always remembered for years. So we make a living by what we get, but we make a life by what we give. So if you want to help coordinate next year's discussion series, you can join me on that. If you have an idea for a topic or a new speaker, let me know. You can email me. And then also, this class wouldn't be possible without Dr. Gandera. She's in the back. And then also Annika and Lon. So I'd like to thank them. Special thanks. Yeah. Okay, so now let me introduce the speaker. Hopefully I didn't take up too much time. Okay, so Lois Thetford is the founder of the 45th Street Clinic, part of Neighborcare Health. She's provided direct medical to homeless people for 27 years. For 23 years, she went into DV shelters, schools, and daycare centers for homeless children and created positive healing interactions for people with many medical issues and many barriers to care. She has trained and supervised RNs, ARNPs, PAs, MDs, NDs, LMs in how to care for high-risk populations. She's on faculty at MEDEX, Northwest Physician Assistant Training Program, the School of Medicine, the Dept of Family Medicine, and has been on faculty at Bastyr University. Let's welcome Lois Thetford. All right, you need this.
Is that working? Yeah. All righty. So, does this go over my head? I don't know what this does. Whatever. All right. So, domestic violence is part of a much larger category, which is now sometimes called intimate partner violence, and sometimes includes elder abuse. It is a huge problem, not just in Washington or in the US, but everywhere. Different cultures, it shows up in different ways, but it's definitely a huge problem, and it is very costly in human costs, in dental costs, in medical costs. It's really a huge problem, and it is a fatal problem. So lots and lots of women are murdered by former or current partners. Most often they are attempting to leave or have left or are being prevented from leaving. So in Washington between 1997 and 2007 there was 430 deaths from domestic violence specifically. A lot of times children are present and sometimes they are also killed. So it's not just heterosexuals that have this. It occurs in all relationships where intimate partners have poor skills in working out the problems of the relationship, and it is also not specifically about love. Domestic violence is about power. Elder abuse is sometimes there is elder abuse that is part of domestic violence, and sometimes elder abuse is outside of the family, but it also occurs in the same context. And it is an increasing problem for all caregivers. All right. So the elder abuse reporting and response Yes.
I don't know if we're allowed to ask questions in the.
Oh, yeah, sure.
I'm curious as to know if the elder abuse is happening in homes of family members, or is this happening in medical places?
Aha. So the statistics that we'll get to show a lot of family violence specifically. The kinds of things that happen in facilities are most often neglect, but not usually direct abuse. So as a founder of the 45th Street Clinic, I have worked in this field since 1975, continuously. And back when HMOs were first invented, all the community health centers in the state got together and formed our own group, which is called the Community Health Plan of Washington. So it's actually a coalition that we created from the community health system when it became necessary to have an HMO kind of thing to do the insurance the way it is now. And so I was on the committee that helped write up all the credentialing things for the Community Health Plan of Washington. And we reviewed every incidence of nursing home, every nursing home that had any kind of a complaint. We actually evaluated all those and said, we don't want any of our patients in such and such a facility unless these things get remedied and so on. So there are actually quite a lot of institutional ways to try to address the medical neglect issues. Sorry. All right, so domestic violence laws have gotten a lot better. The problem is that restraining orders are not entirely effective, but they do sometimes help. Actually, being in a shelter reduces reassault by a lot. And one of the statistics is that women who live in communities without shelters often need lethal means in order to escape, which means they have to kill their abuser in order to leave. And that, of course, leads to many other problems. So, victims are usually financially dependent on the abuser, and they're very fearful. So they usually refuse to testify, even in situations of grievous injury. So the Washington legal establishment wrote a new law that came into effect, I think it's been about 15 or 18 years. So you can prosecute domestic violence without having the victim testify. The victim does not have to be willing to testify. The state does the prosecution as opposed to the victim. And that actually works a lot better. The Seattle Municipal Code has a law that says that if the police are called to a scene of domestic violence or intimate partner violence, that one person has to be removed, and the police have to figure out who should be removed. They have found that this actually really defuses the situation to a certain extent. They can't always tell who is the aggressor, because a lot of times abusers are extremely manipulative and very good at tricking people into appearing worse than they would otherwise be. So sometimes they remove the person who's actually the victim and not the abuser, but at least they're not in the same place, and there's a legal process that investigates it, and it actually helps sort out what's really going on. So domestic violence and intimate partner violence is not a mandatory report, whereas child abuse and elder abuse is. And that unless there are major injuries. And so misdemeanors in the city of Seattle go to the Seattle Municipal Court. But if there is injury that is elevated to the felony level, then that goes to Superior Court. And with elders, you're supposed to report any kind of injury that's not, you know, something that you could get just by knocking into something accidentally. So what they call first aid injuries. All right, and this is a homeless place where people donated a lot of those little hotel soaps and lotions. It's one of the things that we do is like donate toiletries and collect things like that, because when people go into shelter, they have nothing, you know, period. All right, so the healthcare for violence victims and survivors is usually an emergency room, but it can be an office visit, and or it can be a dental visit, because a lot of damage happens around the jaw and the face. And so many people have to have a lot of repair to parts of their face and jaw. So if you have a population that's already in shelter, it actually helps because they have gotten to the point where they really admit that this is a problem, that their safety and their children's safety are important enough that they need to leave the home, whatever kind of home that is. It can just be a car, but to live in the shelter. And then there's a lot of rehabilitation that happens in the shelter environment. So family shelters are actually very different from the kinds of shelters, other kinds of shelters that you may have learned about or seen, which are, you know, sort of gymnasiums with mats on the floor kind of thing. Family shelters are almost all rooms where the whole the mother and children are in an apartment. They cook for themselves, and you know, especially if there's really little kids and babies, you really need a very contained environment for their safety, for their rest, and so on. And so there's quite a few family shelters and domestic violence shelters in the area. Domestic violence is the cause of the majority of family homelessness. So of women and children that are homeless, it's 65 to 75% who are homeless because of domestic violence. All right, so as a healthcare provider, your first job is screening. Okay, so how did this injury happen? Support. Looks like that hurts a lot. Let's see what we can do to help you. Realistic expectations, which are if the person is still living in the same home with the abuser, you offer information, you offer safety planning, but you cannot expect that every one of those people is going to say, oh yes, I'd love to go into a shelter, because people don't want to. And you have to have very realistic expectations of how much time it takes for people to sort this out. So usually women leave 5 or 6 times before they are successful in ending the abusive relationship. And it's usually because there's children involved, because she leaves the home, she has nothing, and that's hard on her and hard on the kids. And to understand the systems and the barriers and problems with access. All right. So residents have full responsibility for their children. Their children are never allowed to walk around the shelter unattended. They have to be with them or have a babysitter or someone else with them at all times. So as a provider, when you have a patient who is a victim of domestic violence, you have to find ways to build trust. And usually people are not willing to discuss the abuse. They're, until they know you really, really well. They're usually not willing to admit the abuse. And so it often puts you in a situation of trying to do a lot of reaching out and engagement when you're trying to discuss, okay, what happened with this injury, and what's possible to fix in the short term, in the long term. So you explain what you can do and what you can't do. You offer information. Safety planning involves giving people like little cards or phone numbers. This is where you call. There's actually a central number for domestic violence shelters in the city of Seattle, I think in King County. And so they just have to call one number and say, this is my situation. I have this many children with me. I need a place to stay tonight. And so it's all centralized so that they try to make sure that everybody gets a place as efficiently as possible. When you're talking with your patient, you have to assess readiness to change. So that falls into the risk reduction, harm reduction category. Domestic violence is like that. There are steps, there are stages. And if you have a patient that you're working with, you will need to do that kind of harm reduction thing around being the subject of injuries. And definitely talk to other providers. So if they're at a shelter, connect with the shelter case. Every person has a case manager. Always make a follow-up plan. There are a lot of screening aids. This one is from the Nursing Research Consortium. There are ways one of the things they do is to rate and map injuries by the level of violence and lethality. And the other important thing is to understand that there is a cycle of abuse. So abuse is about power and control. It's not about love. So it involves economic control, physical control, and sexual control. So the victim is usually isolated. That is, she's cut off from family and friends. Sometimes she's not allowed to leave the house, even for medical care or anything else. Like sometimes when we would have a family that would get into shelter, they would have not been seen by any practitioners for like 2 or 3 years because they were not allowed to leave the house, and they were threatened and very intimidated. All right, so then after the abuse, the abuser then shows remorse, asks forgiveness, but then transitions to saying, well, I didn't really hit you that hard, or you're whining about that bruise. It wasn't that bad, and so on. And if you hadn't done that, if you hadn't said that to me, I wouldn't have hit you. So making it the victim's fault. So that's kind of how the cycle goes. Domestic violence families, both children and adults, have a lot of post-traumatic stress. I've seen children who stopped talking at 4 or 5 years old because they witnessed such intense violence that they just gave up even trying to communicate with anyone. They were like, I've seen 3-year-olds who were in such dire situations that they could not play. They had no play in them, which when you see a 2 or 3-year-old that can't play, this is a horrible thing. It is so sad. But they have, so these are the symptoms of PTSD, and they have them. They have all of them. So in terms of acute injuries, you frequently see bruises, fractures, broken teeth, broken eardrums from being beat on the ears, blunt trauma, which also is a real good way of breaking the jaw, head injuries, and with elderly, it's you look for skin breakdown. It takes a lot less to injure an elderly person than it does a adult. Okay, so a lot of times your clues are that there's not a reasonable explanation of how this injury occurred. And sometimes it's like, oh, this hurts and that hurts and this hurts and that hurts, and you just kind of can't pin them down. When there's been a real serious injury and there's been a delay in seeking care, like particularly broken bones, things like that, you know, that it takes like 3 or 4 days for the person to come in, that's not normal. If people break bones, they want to be seen for the most part. And so delay in care is a clue that there is a serious problem here. The comorbidities with depression, anxiety, and other mental disorders. So pregnancy increases the risk of domestic violence by quite a bit. So always question pregnant women if they're safe at home, if anyone has hurt them or forced them to do things against their will. Substance abuse is sometimes a comorbidity. It's not as common as it was thought when they actually studied it. But there's usually a history of some abuse in the family. And if during the visit the patient is not allowed to talk and the partner does all the talking, then that's also a suspicious sign. Sexual abuse and rape are a big part of domestic violence, and those present with bleeding, pain, pregnancy. I had one patient who had, she had 5 children before she was 22, and she was not allowed to use birth control. I mean, she was just simply not allowed to have birth control. And she couldn't take care of all of them either because she was damaged herself in a lot of different ways. STDs, exposures, rectal tears, and incontinence, those often are consequences of sexual abuse and rape. And HIV. So, 3 in 10 HIV positive women were abused as children. They all had a history of sexual assault or domestic violence in the family, often leading to a drug use, exchanging sex for drugs, money, or shelter, which is called survival sex. And a lot of our homeless youth are forced into that on occasion, which causes you to have an increased exposure to HIV. They also, lacking financial and physical independence, they were not good at taking care of themselves, and a lot of them were actually assaulted when they told their partner, yeah, there it is. 1 in 4 women were assaulted after they admitted that they had HIV to their partner, even if the partner might have been the one that gave it to them. Often prevented from seeking care, being outed as HIV positive to the children, to the school, to the family, causing a lot of shame, just another kind of control, calling the abuse victim contaminated or dirty, and just shaming them so much that they really have trouble standing up for themselves and trying to sort things out. They just they feel very destroyed emotionally by this abuse. People who are gay, lesbian, bisexual, and transgender are often isolated from their families, so they may be more dependent on their partners than heterosexuals. And a lot of times, the issue of children is one of the things that makes managing their care very difficult, because they're very worried about what will happen to their children, and at the same time they don't know how to take care of themselves. So there's a lot of chronic pain that we see in people who have had abuse, even years and years before. Sometimes it's because there were like major injuries. Like one patient, her thumb was kind of torn off, and it took like 7 surgeries to attach the tendons back on. Because your thumb is pretty complicated because of going around like this. And she couldn't use her right hand for a really, really long time. Rebuilding the facial bones, rebuilding the jaw, very complicated surgeries and very extensive things that we see. I had a patient with chronic bowel and bladder problems, and she said, well, you know, he threw a refrigerator on top of me. It's hard to imagine, someone picking up a refrigerator. Can't have been a huge refrigerator, because she would no longer be here. She was a very small person, but she had totally messed up her internal organ stuff, and she just she just had many things that didn't work for her, and she never felt safe anywhere. So she never had a place that she lived. She went from shelter to friend's house to, like, she was always moving. She never ever settled anywhere, because she was sure that if she ever stayed anywhere for any period of time, that he would find her. She was very distressed. So you can't tell by looking. Couples can seem very, very pleasant and agreeable, and you just don't know. All right, so a couple of cases. So the first one was very interesting to me, because I asked her quite a few times, you know, sort of what was going on, and she denied that he hit her from the beginning, and she came in because she felt like she was the problem, and that, well, she was off her bipolar medication because she'd moved here from California, and, you know, she just needed medical care, and she had quite a few vertebrae broken in her back and all these things. And he comes in and says the same stories, and finally, months and months later, she admits that actually it's a domestic violence situation, and she moves back to California with her kids. But it was really unusual, because they both came in with this story about how she's the aggressor and she's the person who does these mean things, and really, you know, they were both covering this up, but with quite an elaborate story. This was a mom that I saw at the shelter, and she was there for a year. She did very well during that year. She improved a lot of her function as a mother, and, you know, sort of moved much more into an adult role. But she moved back to the reservation. The abuser moved back in. She asked him to leave. He left, but he returned with a knife, and she came back to the shelter to see me, and she had 300 stitches in her face. And she lost her kids, because CPS said, clearly you're not able to protect your children. So she was, I mean, it was a heartbreaking thing to see her. I mean, it was good she came back, because she, she needed to talk to people who saw her as a responsible adult and had seen her being a good mom. But she had a very sad life. She was with this person from the time that she was like a teenager, and she never, I mean, up until this point in her life, she had never been seen as a responsible person by her mother or her husband. She had a lot of negative stories being directed toward her. Okay. So, when you're talking to people who are abused, you need to be compassionate, but you need to actually also control your own emotions. A lot of times, they'll tell you things that are so horrible that it makes you want to cry, but don't cry. Because they're the ones who need to be able to feel about that experience. And if you take up the emotional space by, overreacting as they would see it. I mean, between two people who haven't been in an abusive relationship, it's like, I can't believe the refrigerator story. I mean, that's crazy. But if you're that person, and people say, I can't believe that story, you're devaluing them. So it's very tricky about being compassionate, maintain boundaries, explain the limits of confidentiality, which I'm sure you've gone over many times, help people understand symptoms that it's not all in your head, but your body and your mind are connected, sort of like the positive side of understanding that, as opposed to the dismissive thing. I don't see anything wrong here. It must be in your head. So cultural sensitivity is very important because of the role of the family in whatever culture you're dealing with, whether it's Samoan or Italian or whatever. Okay, and always be positive. So like with this woman, I talked with her a lot about all the good things that she did with her children. The ways that she was a good mom. And, gave her hope that she would move past this very low point in her life and rebuild. So this mom was married to somebody in the military, I think. Yeah. And she was from Germany. She spoke reasonably good English, but she was really very intimidated. And she had a 4-year-old daughter, and she said to me, I just feel like I'm such a mess that I can't give my daughter everything that she needs. And so when I said, well, we have respite care and this and that, she would say, no, 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 no. But later she told to me that what she heard was, you're not a competent mom, you're not able to take care of your child, and that she was hearing in my offer of support for respite care the same thing that her abuser told her. And I mean, I was happy that she told me that that's what she heard, because you need to know how it's coming across. But if everyone who talks to you says negative, bad things about you, it's pretty difficult to hear something positive. So you have to be careful how you try to do that positive thing. But you do need to find ways, say, I'm really glad you came into this appointment. Something very basic. I think it's important that you get care. It's a tangled mess, and you just have to start wherever you start, and you'll get through it. So this is an elder case, but it was a situation where the woman had become disabled, and the husband was the paid caretaker under DSHS. They had no children in the area or relatives. And they kind of, oh no, this is Ballard. Sorry, this is my Ballard one. Yeah, so these people came in and they had a lot of complaints about each other. And we did do quite a bit of examination and mental status testing. Yeah, there we go. Mental status testing. And he was having dementia and she was just not functioning very well. And they needed a completely different living situation to protect them. Okay, wait. All right, I just want to say this thing. For elders, they're safest living in families with strong social support. So like this situation where people of all ages are mixing together, and they're at greatest risk when they're in isolated situations where, especially if the caretaker, which frequently is daughter, daughter-in-law, son, or son-in-law, has mental illness like depression and substance abuse, then the elder is in greater danger. Yeah, most of the victims are women. Spouses are more likely to abuse than children in taking care of their elders. All right. Oh yeah. So this case I won't go on at length about, but you should look it up. Linda David, it was a huge case here in Washington. There's a lot written about it. It was, okay. And the last part here, for interprofessional collaboration, it's really important to know what the other providers are prescribing to your patient. So for pain, for anti-anxiety and psychotropics, all those things have synergistic effects that can affect mental clarity. Most domestic violence victims do have dental damage, or else they've just not seen a dentist ever. And so there needs to be medical care, dental care, psych care, address any functioning issues, substance abuse, and so on, and parenting, because there's almost always children involved. All right. So this is it. All right. Well, there's more, but I will stop. How about questions? All right, but there's one very positive one. Let's see if I can find that. Yeah, here it is, case 6. We'll close on a really good one. So this woman was in an abusive relationship, but it was not physical. It was psychological and verbal, and she often came in very distressed, but she would not leave until her children graduated from high school and went to college. And so every year at her yearly exam, she would report the same situation. But when she was 46 and the kids were not in the home, she divorced, she began a new life, and she came in to report that she was vibrant and strong and a new person. And she said, I always knew that I could get to this point, but I wasn't going to leave because I couldn't support the children. So she had a plan, her plan worked, and so the job of the practitioner is to assess her safety. She was physically safe. There was no weapons, there wasn't physical assault involved. I had to be very patient and listen to her complain every year about how terrible it was and that she wasn't going to leave. And she came through just fine. Okay. So there's lots of information on the web that you can find. Okay, great, well done.